Good afternoon, colleagues and ladies and gentlemen. It's my great pleasure to welcome you to our virtual 2021 Last Lecture. Now, before we begin, I'd like to acknowledge the traditional owners of the lands on which we gather and pay my respects to elders past, present and emerging. The last lecture, as many of you know, heralds the end of the second major teaching semester for the year and moves us towards the end of the regular academic year. And another extraordinary year it has been. To all of you out there, to our students, to our academic community, to our professional and technical colleagues, I simply want to acknowledge the hard work that you have all put in this year, and indeed acknowledge other members of the community who are here who no doubt have found challenges in 2021 as well. Now, I'm really pleased to let you know that this lecture has special significance for our university. It's been held each year for the past 12 years, and it's an opportunity for our colleagues to let us in on some of the terrific and extraordinary work that people do across our university every day. And normally what we do each year is identify and focus on a particular issue of contemporary significance, both to the university and to the broader community. And I'm just delighted to let you know, as you are already aware, but to reinforce that this year's last lecturer is Professor Emma McBryde. Now, a few comments about Emma McBryde and about how we're going to pass the next 1 hour together. So Emma, for those of you who don't know her, is a Professor of Infectious Disease Epidemiology at the Australian Institute of Tropical Health and Medicine, AITHM, and the lead physician for the Tuberculosis Control Unit at the Torres Strait and Cape York Health Service. Now, you may have seen or heard Professor McBryde in the media over the past 18 months as Australia has navigated the COVID-19 pandemic. Her research and expertise in infectious diseases, mathematical modelling and epidemiology, and as a biostatistician, has seen her called on for advice from the highest levels of government and, of course, through the media too. Emma has provided COVID-19 modelling and advice for the Commonwealth Government, for the Victorian State Government, AusSage Indigenous Working Group, the Global Fund Against Malaria, TB and AIDS, and the World Health Organization in conjunction with countries in the Asia-Pacific regions. Emma has spent the last 15 years interleaving clinical research with mathematical modelling and simulation of infectious disease transmission. She leads a small team of highly skilled mathematicians and biostatisticians, epidemiologists, and a health economist at JCU. She's led research teams to complete international consultancies, modelling of tuberculosis control in our region, and international research collaborations in the area of tuberculosis, healthcare associated with infections like SARS and Ebola, and COVID-19. Emma's lecture is titled Our COVID-19 Teacher: What We Have Learned About Epidemics, Public Health Response and Ourselves, Reflections from an Infectious Disease Physician and Modeller. She will provide some insights into what public health actions could have and should have happened differently, and what went right too, and how these can be improved in the future. Emma will explore how models have been used in the pandemic and what insights they may give us for future preparedness. And she will also reflect on the personal journeys that she's had and has witnessed during the pandemic. Now, to let you know, Q&A is enabled, so not chat. If you could use the Q&A button, please, that would be really terrific. If you have any questions, please put them in that area through the Q&A button. I'll keep an eye on those and I'll raise questions as we proceed where that seems to make sense. And indeed, we'll have some questions at the end. So without any further ado, I'm now pleased to welcome Professor Emma McBryde to present JCU's last lecture for 2021. Over to you, Emma.
Good start. Okay, thank you very much, Professor Harding, and it's a real honour to be able to give the final lecture. Obviously, COVID has thrust some of us more into the limelight than we're used to, and I can see that I hope this will be a novel and contemporary issue that we're all sort of wanting to get over at the moment. So hopefully this will be the beginning of the end of the focus on COVID. So I took my titles from this fabulous movie, feature film that I've really enjoyed this year, which was My Octopus Teacher, because of course this octopus has much more of cuteness and intelligence than COVID, but in some ways I feel a little as though COVID had a similar impact on our lives as the octopus did in the individual in this feature film, in that it's made us reflect quite a lot on what our priorities are and how to do things differently in the future. And it has, in some ways, certainly some similarities about it. And I'll keep referencing this in my talk. So I'm, as has been said, I'm Emma McBryde. I work at the Australian Institute of Tropical Health and Medicine. And I will get on with my talk now. So what I'm going to do is really take you through the COVID epidemic from an Australian perspective and from an epidemiologist perspective. So essentially chronologically, I'm going to talk about what happened at the start, what we might have done differently. Then I'm going to indulge myself in a little bit of modelling, because that's my favourite topic, and talk to you about that. Reflect on what happened in the second half of last year in Victoria, and perhaps what could have been done differently back then. I will segue into a little bit of discussion about the disease itself, because without understanding a tiny bit of virology and immunology, we can't prepare ourselves to talk about vaccines, variants of concern, and the rise of Delta. And then finally, at the end, I will sort of reflect on what might happen now. So let's get started. So what happened at the very beginning? So as many of you will remember, it was about early January that we first became aware of this new coronavirus, SARS-like coronavirus, didn't have a name at the time, that was happening in Wuhan. And it wasn't until the 23rd of January that Australia started screening people who were coming from China. And within a couple of days, 4 cases were detected coming in from China. And just a week later, Chinese arrivals were blocked from Australia. So we no longer took Chinese tourists, much to the chagrin of the Chinese government and also the World Health Organization. But it was actually another month before anyone else was blocked, starting with Iranians, South Koreans, Italians, and then we sort of, the penny dropped that we just had to close our borders to non-Australian residents, and even Australians returning had to be quarantined. By this time, we had community transmission, and we had to do a lot more than that. We had to shut down to various levels, including stay-at-home orders in late March. So you'll remember, so what happened in this month and the early parts of February before we closed our borders down completely? You might remember that Missy Higgins' dad returned from the US and was told, you don't need a test, you don't need to quarantine, you're fine, you came from the US, not a problem. You're not from Iran and you're not from China. And felt sick and got tested and was tested positive and got really thrown under the bus by our health minister of Victoria at the time. So there were some clues early on that the virus was far more widespread than we believed, far more widespread than our policies were managing. And remember also Tom Hanks and his wife went to the Gold Coast from the US and tested positive there. That was all happening in the first half of March. And so I think what we can learn from that is that by the time we knew about COVID, it was much too late to be trying to use, I guess, global intelligence to work out where it is in the world. We have to use other means. By the time we knew to close our borders, we had circulating virus in every jurisdiction, apart from perhaps Northern Territory, where we really had no community transmission. And we had to undergo those desperate measures on the 25th of March, where we saw people lining up in their tens of thousands because they'd all lost their job, people who'd never been unemployed in their lives. So if we had locked down earlier, could we have avoided the vast majority of these loss of livelihood and needing to undertake such dramatic local control measures? And I think the answer to that is yes. And some of the modelling that we've done has tried to address this head on. We've got a model of the way people move around the world through international air travel. And it was very clear that if given enough time, and by enough time, I just mean days and weeks, by the time we found out about the virus coming from China, the epicenter had already shifted over to Iran initially and Europe, and was probably at very high numbers in the United States as well. And Australia was at least as much risk from people coming from the United States as they were coming from China. And by the time we locked down, we had let in a large number of people. And this is some modelling that shows what would have happened if we hadn't closed our international borders. The black dots, so the horizontal axis is just the date, and vertical axis, the logarithmic cumulative mean number of cases, and the black dots are what we actually observed. If we had not blocked our international borders at all, the predictions are that things would have really taken off in this exponential fashion. If we locked the borders but didn't do anything about the cases in the country, then things would have also taken off in this exponential way, but with just a slight delay. So we really needed to do both. And in fact, that's exactly what we did. We did both. And here is, this is about the 10th of March, before the real staged lockdowns took place. And we know that we actually managed to really extinguish the first wave of infection through a very dramatic action, which was incredibly expensive, with the job seeker and job keeper funds. All right, so in summary, yes, we could have avoided the first wave by locking down in February rather than in March, and avoided the majority of the cost of job keeper and job seeker. However, what's our appetite for doing that next time? I mean, in 6 months' time, when we're back traveling around the world and someone says, oh, there's this new thing that's a bit like COVID, or a new Delta Plus variant, let's lock down again. Are we going to do it again? Do we have the systems in place and the resilience in place to allow that to happen? And as I think as North Queenslanders, we know that the people who are really dependent on international tourism and international students and so on have not been well protected in this pandemic. And so it's going to take a big change in the way we think about pandemics to be able to, I guess, go lock down sooner and take the risk of having, if you like, a false positive, locking down when we didn't necessarily need to.
Emma, there's a question from someone just while you're
Sure.
in these early days,
Yep.
and it's this: why didn't the Commonwealth Government acknowledge the possibility of the risk of transmission in children early in the outbreak?
Oh, okay. I'm going to talk a little bit about children. So children. So why didn't they? I mean, in most of January, we're talking early days here, we were still debating whether it was transmissible at all. So it took a while for us to realise what was going on. Children transmit for sure, but they do so at lower rates than adults, and they are less infectious and they are less susceptible. Not entirely uninfectious and not entirely unsusceptible, but certainly for the original variant, they were less. And so it's not, I don't think anyone has said that children can't get infected and can't be infectious, but they certainly are, have lower risk of, lower rates of both of those things. So I'm going to talk about that more a little later in the talk, so I'll leave it for that for now, if that's okay. But what I might talk about next, if that's all right, is a little bit about modelling. And the question that I frequently get asked, which is, why did modelers overestimate things so much at the start? Why have we been like such drama queens, if you like, saying that things were going to be just terrible? And here's another question. You know, we've had about 1,500 deaths. We've had about 130 cases. Less than 1 in 10,000 Australians have died. Why are we worrying when there's other diseases and conditions that actually cause greater amounts of death? And that's true, but I think the answer comes in the form of a model, because what people don't grasp is what the exponential rise in cases actually looks like. So I'm just going to talk you through a very simple infectious diseases model where people have various states that they can be in, fully susceptible to a virus. And then if they do get infected, they either go through an asymptomatic infection, that's about a quarter to a third of people, or they go through a symptomatic infection, which starts before, first of all, you have no symptoms, and then you get symptoms. And of course, it's these people who can have severe outcomes. And infectious diseases models, mathematical models, all they do is they quantify these flows and what drives them. And what drives the infection flow is, of course, having infectious people here, all of these people in reddish orange, mixing with susceptible people in blue. And if you turn this into a model where you allow that this mixing happens really homogeneously, like people just bounce around and infect each other like molecules might change state, for example, if you just do a very simple model like that, the consequences are that you have, okay, so the consequences are that if you have a reproduction number greater than 1, you start seeing people, an epidemic occurring. So I'll just quickly remind people, reproduction number, this is this number that prime ministers around the world now are familiar with and have used. It's the expected number of new cases that a typical infectious case will make. And for the original COVID, it was estimated to be 2.4. All right. So if you're an infectious person, on average, you infect 2.4 others, assuming that everyone around you is susceptible. All right. So at 2.4 reproduction number, the models estimate that the final size, in other words, the total number of people who are drawn into the epidemic from the start to the end, is about 85%. So if you think about 85% of Australians getting infected, and I don't think that's too unrealistic. I think most people in Australia will contact COVID sometime in the next 2 years, even unless we do something very special with vaccination. And then you think about 1 in 150 or so of them dying, we're talking about 150,000 deaths. So it's dramatic. So you could say, okay, well, that's a very simple model. Things are going to be different when you look at the fact that people only contact another 20 people on average in a day, and that we don't bounce around like molecules. But in fact, I'm just going to show you in this next slide, which is the estimates that my group made about the case numbers, assuming a reproduction number of 2.4 or 1.6. And beside it is the estimate from the Imperial College, and they had a very, very complicated model. People had households and went to school and came home and went to sleep and did all sorts of things in their model. It was an agent-based model, and the results are very, very similar. So it's not because the models are simple that we didn't see what the models predicted. The models predicted what would happen if we just pretended nothing was going on and just moved on with our lives and completely ignored the pandemic. So I think the real trick is that the real thing that modelers have to learn is that people don't just continue to behave in the usual way. And here's a chart from Our World in Data that shows the effective reproduction number at the start, and it is, as you see, between 2 and 3 in most parts of the world. But by sort of March, April, it had already dropped down to just a bit over 1 and stayed there. And even with Delta, has stayed just above 1 for most of the world. So there's a behavioral response going on that means that whatever the models predict, hopefully, are not going to come true. And what do you do about that as a model? As a modeler, because if you say, well, look, there's not going to be a problem, then that might lead to a problem. So it's a sort of a catch-22 situation. But certainly the models at the start predicted all manner of overwhelming of the health system and deaths. And it was the behavioral response, which was partly individuals making up their own mind to change their behavior and partly government mandates. It's a behavioral response that drove down the epidemic. And I had a look at this with the actual observed reproduction numbers, and in the backgrounds there's the actual number of cases for each jurisdiction in Australia through March and April and May. This was, of course, of great interest to governments at the time. And what you see is that certainly Tasmania had a problem. I think, I wonder if any of you remember that they had a whole region that they had to sort of lock down and isolate for a short period of time before the Victorian wave came along. And the other jurisdiction that was really struggling a bit was Victoria at this time. But most of the states and territories had their reproduction numbers well below 1 and were driving out the international importations of COVID through April and May. All right. So that leads us to, well, what happened in Melbourne, and what should we have done? What could we have done differently? So this is a controversial topic, and I don't have all the answers. I don't pretend to, but see, some of the questions I've been asked are, why Victoria? What brought it under control? Was it the curfews that did it? The lockdowns, the closing of retail stores, the school closure, mask use, and so on? Did children really need to miss school? And I think after all is said and done, was it worth it? Certainly at Christmas time, we thought, well, that was worth it. That was worth doing in the end. I'm not sure. I think we won't really know the answer to that for a few years. Okay, so what happened? Here's a slide of different clusters of COVID. They were all imported from around the world in March and April, just before we really got quarantine sorted out properly. And here's the quarantine related transmission that led to just about every single case that happened in Victoria in the second half of 2020. So what you can see is it was one transmission event. In fact, it was a chain of probably single transmission events where there was opportunities all along the way to do something, but something wasn't done until we got to around about this point in the epidemic. And at that point, things started to be done, and I'll talk a bit more about that in the next few slides. I might just contrast that with New South Wales, where again, what we've got here is every colour here is a cluster of cases, and we've got time on the x-axis here. And what you see is all these bunch of importations, but when the stay-at-home order came in, we really squeezed out the cases, and clearly the effective reproduction number was falling and was well below 1 until virtually elimination. And then all of this green in the second half of 2020 are people from Victoria who came into New South Wales. That took a bit of time to track down, but it was very targeted, very specific to the context. So I guess the lesson from that is that in New South Wales, they were able to defeat COVID in 2020 by targeted and specific measures that wasn't possible in Victoria. Now, we know it now, a year later, that New South Wales tried the same thing again with the Delta variant and failed with that. Delta variants are very different infectiousness, and that's something we'll talk about in a moment. So, excuse me. So my group joined a group in Victoria to look at the wave in Victoria and how we gained control of the second wave. And again, we used modelling, this is really the same model I've already described, except we bring in age. So we know that the severity of outcomes is very age dependent. Whether or not you get symptoms is age dependent, how infectious and how susceptible you are is age dependent, and how you contact each other is age dependent. So that also was included. So suffice to say, it was an age-specific model. It also looked at different local government areas. So it was very compartmentalized, getting quite a complex model by now. And what we were trying to do is try and work out which of these various components of the public health response made a difference. Face coverings became compulsory towards the end of July, and the cases really turned really at the end of July. But did lockdowns also have some kind of impact? So what we did is calibrated the model and considered all these different public health interventions, including masks and lockdowns, and looked very carefully at the way people moved. This is a Google mobility report, and we could track differences in movement and correlate that with where and who was getting infections. And the bottom line is in our estimate, face coverings were very effective. They reduced the effective reproduction number to about 0.5 of the original amount. So they were 50% effective, and that's overall, like over the whole day and all your contacts, not just while you're wearing them. And physical distancing was also crucially important in controlling the Victorian wave. So we needed both, and it's, something obviously worked, and we believe it was both mask use and physical distancing. And if you look at how Victoria fared compared with every other country in the world that got to the same kind of rate of cases, we were just about the only country that was able to drive it down in Australia. So we did so with incredibly stringent public health actions. That doesn't mean to say that they were all necessary, but something had to be necessary. And I've got my own theories. I know that mask use was crucial. It wouldn't have happened without the use of masks. But I don't think that all of the others were crucial. But then again, we didn't do them in a rigorous randomized control trial way. So perhaps we'll never know. We haven't learnt too much indeed. But what we have got is just for fun, I guess, we're looking at some counterfactuals. If we had done, this is the black line here is the whole of the second wave in Victoria. And if we'd done nothing, we're estimating that things would have just got out of hand. And if we'd only done mask use or only done lockdowns, things would have also got out of hand. So it did require a very solid response to get to where we got, to actually eliminate COVID from the point we were at. Okay, so I will just quickly talk to this question because people ask me all the time, and we've already had a question about this around children. Did schools really need to shut down? In order to answer that question, I need to talk to you about these contact matrices. So these funny pixelated things are age by age, numbers of contacts that people have, all right? So this little pixel here represents, so it's 5-year age groups. So the first, 0 to 4 years, contacting 0 to 4 years, 5 to 9, contacting 5 to 9. So you can see that people like to hang out with people of the same age along here. So this is how many contacts you have a day. And in the home, there's also this off diagonal, which represents parent to child, child to parent, and so on. And at school, there's obviously people contacting very much people of the same age. And there is a little bit of something with teachers contacting children, but it's incredibly small. And if you look at that and compare, and think about also that children are less infectious, at least slightly, and less susceptible, quite a lot less susceptible, then you can show that the impact of school closures for the original variant was virtually negligible. I don't think we can say the same thing for the Delta variant. So I don't want to be too dogmatic about that. But I think school closures were the least important component of the public health response in Victoria last year. All right, so after that little controversial component, I will move on to the Delta variant, new mutations and variants of concern and vaccination. And to do that, I'm going to show you a nice video. I hope you'll enjoy it. And then I'll talk a little bit about virology and immunology, just enough to cover off on these topics. So let me play a video. This is one of my favorite websites called Next Strain, where we basically do a family tree of COVID, and the grandma's ancestry is over on the left, and the granddaughter's current situation is on the right. And you can see each COVID isolate is slightly different from the others, and they're all stacked up like this and clustered together as required. And what you can see is, because they change so much, and because there's so much selection pressure going on over time, we are seeing rapidly changing viruses throughout the world. And here in around about Christmas time, the Alpha variant really came to dominate, because it was 50% more infectious than any other variant, got quickly selected for and started taking over the world. And then we saw beta and gamma, and those ones were a worry because they had a little bit of immune escape about them. They weren't quite as amenable to our own immune system or vaccines. And they became a little bit concerning for a while, but then Delta came along, and Delta just took over and pushed everything else aside. It was twice as infectious as the original variant, and that's why it survived, and that's why it thrived. And so you can see all this unfolding using the phylogenetics that you see from this website, which is awesome. And you can also see geographically how widespread it became. So moving on, and that's the sort of why it happened, evolution and natural selection. So it can appear as though this COVID is a beautiful, intelligent creature that's really learning, but in fact, it's not at all. It's a mindless creature that is randomly mutating and selectively evolving to become as successful as it possibly can. So what's it actually doing? Like, what is the mechanism here? So I'll just quickly talk you through a tiny bit of virology. COVID is an RNA virus. It has a lipid membrane, and on this lipid membrane, it has spike proteins and a number of other proteins inside the core and capsule. The spike protein is very important though, because it's the one that latches onto our own receptors called ACE2, angiotensin converting enzyme 2, and helps it make its way into our cells. And what it does is it pulls the virus lipid membrane and makes that kind of fuse with our own lipid membrane. The virus enters the cell, takes over our machinery, starts making copies of itself, and then buds away. All right, but it has to do this several times over, kill several cells along the way before it starts feeling sick. All right, meanwhile, our own immune system has noticed that this virus has turned up and started prompting the adaptive part of our immune system to get ready and to start making antibodies. The antibodies in turn, they attack various bits of the virus, but their most important antibodies attack the spike protein of the virus and stop it from entering cells. And all of that immune response takes a week at least, a little more, and it's kind of what happens in the meantime that determines how sick you get. All right, so we can talk about children a little bit. A couple of things about children. They have less of this ACE2 in their lungs. So that's interesting. They possibly have a few lurking antibodies from previous coughs and colds, but so would we all. So I mean, that's one of the hypotheses as to why children don't do so badly. One of the main things is children have a slightly different immune system that doesn't. So what happens in this, when I said there's this 7 days between when we get really good adaptive immune system and when the virus starts attacking our cells, is sometimes we can have a very exaggerated, exuberant immune response that is really bad for us. And children tend not to do that the way that adults do. Okay, so what is so special about Delta? All right. All the variants of COVID are really just substituting out different amino acids, and predominantly, not surprisingly, predominantly to do with the spike protein, and even more specifically, the bits of the spike protein that like to attach to our receptor. So it turns out that, that there's not that many tricks in the box in terms of COVID. People say, is it going to mutate every year more and more and more and more? We're going to have a booster and a new shot every year. Well, maybe we will, but many of the variants have this mutation. Many of the variants have that mutation, and they've all been selected for separately. So there's a few tiny spots on the spike protein that clearly lead to survival. And they are because the spike protein is better at attaching to this human receptor. Now, the really cool thing, I think, about the Delta variant is it also has this mutation somewhere in its kind of the waist of the spike protein, and it makes it much more efficient, not at attaching, but doing that second job of pulling the virus and the human cell together and making the membranes fuse. And it does that like far more efficiently than any of the other variants. And that's why it has like about 1,000-fold as many copies of itself in a typical human lung. of a person who's infected compared with the other variants. So it's like a huge change. And that's why it's been able to push out all the other variants and is by far the dominant variant in the world at the moment. Okay, so that allows us to move on to another controversial topic, vaccination. So what are vaccines doing? What they try and do is allow the body to see the spike protein before they see the virus. So old-fashioned vaccines did this. They just took whatever it is you wanted to expose your body to, stuck it on an adjuvant and injected it into your arm. And that's fine. That works. That's Novavax. That's what it's going to do. And it's very effective. But these really interesting new vaccines like the mRNA vaccine take just a slice of mRNA that can code the spike protein, wrap it up in a lipid and let that sort of diffuse into your cells. And then you start, like a virus in a way, taking over the cell's machinery and making spike protein. And that way you can have one tiny little strand of mRNA makes dozens and thousands of spike proteins, and you stimulate your immune response to develop antibodies against the spike protein. The adenovirus, so this is AstraZeneca, use a similar but slightly different method where they put the COVID spike DNA, they turn it into a DNA coding and put it inside a replication defective adenovirus. So a safe adenovirus that can't reproduce, and it gets in that way and has to go into the cell nucleus before it becomes mRNA. And again, and this is the common pathway of making spike protein. All right. So this will lead into questions about vaccine side effects and so on. The reason it seems to be that the AstraZeneca causes clots and mRNA doesn't is something to do with the adenovirus being able to stimulate platelets in a way that doesn't happen with this lipid membrane. And the real key is that an antibody called antiplatelet factor 4 gets made in a very small fraction of people, which sets off that clotting cascade. And I can go into more detail if necessary. On the other hand, this lipid particle in the mRNA vaccine can cause a very severe allergic reaction in some people and can cause myocarditis, particularly in younger men. We don't really know how that happens yet, but we know it does. So there are benefits and risks of vaccines. So 1 per million people who receive AstraZeneca will die from this severe clotting disorder. About 1 in 30 to 50,000 will get myocarditis from the Pfizer. There's been a couple of cases of deaths recorded. And then there's also anaphylaxis from Pfizer. Okay, so we have to compare that to the risk of dying from COVID. And, you know, as you go down the age, it gets very rare to die of COVID. You know, teenagers handle COVID extremely well. And the risk of death is only 0.03% in this younger age group. But of course, if you compare that, that's 300 per million as opposed to 1 per million from AstraZeneca. And I think we're not very good at weighing up risks when they're this tiny. And we can talk a bit more about that in the discussion. There are, of course, some contraindications and a lot of people wanting to ask for vaccine exemptions, but I'd put it like this. The severe allergic reaction to Pfizer is about 20 per 100,000. For AstraZeneca, if you've had this strange clotting disorder before, the risk of that is about 1 in 30,000. And sorry about the 0, 1 in 30,000. And so the chances that you have a real contraindication to both vaccines is about this. So in other words, there's a very low chance that even one Australian has a true contraindication to both types of vaccination. So in summary, don't come asking me for a vaccine waiver. All right, this is the final bit of science and mathematics that I want to talk about, which is modeling vaccine effects. So I often get asked, well, look, you know, vaccines only reduce severe disease. They don't reduce infectiousness. So how are you even talking about herd immunity and so on? Or do they induce infectiousness? And how is it possible that if you're vaccinated that you can get COVID or give COVID to another? And so it really just boils down to a numbers game here. So back to our model, vaccines have from a modeler's point of view, 4 different effects, right? And they're all doing, it's all happening through this attachment to the spike protein. Attaching to the spike protein may mean that the virus doesn't even get into your body at all and reduces the acquisition of infection altogether. Or it may mean that it gets in, but it doesn't replicate very much, and you end up having asymptomatic and very low-level viral infection. The infectiousness, even if you are symptomatic, is reduced because the amount of virus in your airways is reduced. And then finally, the probability that you're going to go on and get very severe disease is also reduced. So these are the 4 kind of main components. And there's good clinical evidence that vaccines work in all 4 of those ways. And I've enumerated them, and I've got some references if you want to hear them. But people are probably about half as infectious when they're vaccinated. For Delta, that might be a bit less. It might be more like 25%. We're still working through that. But they're definitely much less likely to acquire infection and become symptomatic, and much less likely to die. All right, so they're the values. So going back and putting this all into a model, what we can say is, right, we're back to our contact matrix again, where we have age-specific contact. We know that children are both less infectious here and less susceptible. So we change this contact matrix based on that. And we know that vaccines make people less infectious and less susceptible. So you can see here, an unvaccinated infected person here contacting an unvaccinated susceptible person is much more likely to cause transmission. So think hot colors, more danger, compared with a vaccinated and a vaccinated. So the risk that 2 vaccinated people are responsible for, several vaccinated people are responsible for a series of chains of transmission becomes increasingly unlikely, even with Delta, compared with vaccinated people or mixtures of people. And that's really what's driving, that's the modeling that's driving the vaccine specific and the exclusion policies that are happening at the moment. And I hope they're temporary, but I think they're necessary for now. Okay, final difficult slide, if you like. Is herd immunity still possible with Delta? And I think that's a question. So we've used that exact model that I just showed you there to think about this question. And if the effective reproduction number is as low as 3, and we vaccinate as much as 80% of the population, then we should be able to achieve herd immunity. We're not quite, this means 80% of the whole population. We're not there yet. We're more like 60% of the population right now, the whole population. And if our effective is about 3, we're nearly there. We're getting very, very close. But if our effective, which is more likely, is about 5 for Delta, we can only get to herd immunity if we go and vaccinate everyone from the age of 5 upwards. And I was very pleased to see that is now our policy in Australia as of last night, which is great. If our effective is as high as 7, we will never get there. We will not achieve herd immunity with the current vaccines and the current Delta strain. But we can get, even if we don't achieve herd immunity, we can dramatically reduce hospitalizations and deaths and cases. All right, so finally, some reflections. Where to from here? And I'll hand over to people to ask questions now. One thing that I would like to say is what's really exciting and promising is just how well vaccinated the older population is now in Australia. 95% plus for first doses for most people over 60 now, which is just extraordinary. Queensland's got a bit of work to do. Don't know, we can talk about that. So where to from here? What will 2022 bring? And what can we expect as Queensland opens up? I mean, one thing I think we can say as Queensland opens up is it's unlikely we're going to have stringent lockdowns. I think our tolerance for that is over, but there's every chance that workplaces will be closed in targeted ways. Schools will be closed in targeted ways. It's quite possible, I think, that Indigenous communities will close. And I think that's, a consequence of the very low vaccination rates in those communities. So things will happen, people will get infected and people will die, but with very, very high vaccination rates, we can have if you like, a soft-ish landing. All right, so I'm happy to take questions now because I know I'm over time. I did want to talk a little bit about my best and worst calls through the pandemic. One of my best calls was buying shares when everyone was panicking, only a few, sadly. And then I panicked and sold them. Another great call was taking my kids out of Melbourne and flying north just before the lockdown. And another, but some bad calls. I really thought in about July, August, that we should give up. And I think in retrospect, it was probably best not to give up. I thought Queensland should open its borders and Victoria should stop torturing its population at around about July. But in the end, we did actually succeed. And had we got vaccines at a good time, it would have been just a remarkable tale. But in the end, we were left with another, 9 months of being on the brink of something, and having lockdowns again in New South Wales and in Victoria. So I also wish that I'd advocated mask use much earlier. It was pretty obvious. I think it should have been obvious that masks were effective, and I didn't advocate them until the peer-reviewed journal paper came out. All right, so that's there's some mistakes I made. I also think there's some mistakes that were made by others. Particularly, I'll point out that ATAGI, which is a very important community of very sensible, serious people who are experts in the field, is probably not fit for purpose for a pandemic. They just were so slow to move on everything that it was frustrating, and a lot of decisions that resulted from that were very unfortunate. Similarly, the TGA, the Therapeutic Goods Administration, so ATAGI stands for the Australian, I can't remember. So Australian Technical Advisory Group on Immunisation, the TGA is the Therapeutic Goods Administration. And of course, quarantine facilities being built in Queensland and Victoria. They'll be ready soon. They'll be definitely ready in time for the next pandemic, but they certainly weren't a good idea for this one. But I'll just leave on a very more positive note about what I thought was surprisingly good in this pandemic. I think the media was exceptionally good at providing information, at providing transparency, and at being genuinely interested in the science behind the topics, and numerous websites, some of which were developed by teenagers with surprisingly well curated and analysed data. The publicly available code in my area of modelling was awesome, and the rapid non-peer-reviewed publication community, as well as peer forums that assess studies very, very rapidly, were great. So I'll leave it on that positive note and anticipate your questions. Thank you.
Thank you, Emma. That's an absolute tour de force, and you'll be pleased to know there are a number of questions for you, and I'm just going to simply take them in the order that they have arrived, and some of them are double up, so I'll try and deal with that. So first of all, there was a question about ventilation. I wonder if there's any modelling data studying how much improving ventilation systems could have reduced the risk of transmission. And the point goes on to say the airborne transmission, improving ventilation seems to have not been much discussed. So that's one for you, Emma. So we're going to speed date these, I think, because we've got quite a few.
Sure. Okay. Now I get to use the slides that I didn't get to use. So here we go. Ventilation is actually quite important, and it's not something I have modelled, but I think it's worth modelling. So mask use is good at reducing droplet spread. And if you're wearing one of those real duckbill masks, it can also reduce aerosol spread. But ventilation is very, very important for this sort of spread, for reducing the spread of these very small particles that hang in the air. And we knew from the start that they were important because we saw, on the, not the Ruby Princess, the other one, Diamond Princess, that people were in different cabins, but air was circulating without being well ventilated, and transmitting from place to place. And we've seen it in quarantine all the time. So yes, ventilation is important. I suspect this is going to become a very expensive process to do something about ventilation. And what we probably really need to do is just open up a whole lot more windows around the place rather than get too technical about it. But yes, I do think ventilation in schools and workplaces is going to be a big focus over the next few years. This is not over yet. And had we had better ventilation, could we have reduced the effective reproduction number to less than 1? I don't know. It doesn't stop droplet spread, right? It doesn't stop someone sneezing on someone else or very close to someone else, but it certainly stops the aerosol spread. It doesn't stop the fomite spread or the direct transmission spread. So whether it would have made that much of a difference, you know, I think those questions will are for the future, and also they possibly vary with the Delta variant compared with the original, which seems to be more aerosolized spread, where ventilation is becoming increasingly important. But it's a good point and good question.
And look, and following on from that, there are a few questions about is there any connection between climate change and COVID? For North Queensland, you know, people are trying to struggle, I think, with how is it that we've seemed to have escaped you know, a lot of the brutality of this, and maybe it goes to the point you've just made around an open style of living as much as anything. But anyway, people are curious about the connections there.
Okay, so climate and COVID, certainly COVID prefers a cold and dry climate, and so there is an element of protection about being in the tropics, but then you only have to look at Indonesia and India and see that it certainly doesn't make you immune, you know, it doesn't provide that much protection. So there's it's a numbers game. So yes, it reduces the amount of time that COVID will stay on surfaces and so on, but it doesn't, you know, so the other features about Queensland, of course, is we have a relatively low population density, relatively low use of public transport, I mean, really, and a lot of outdoor activities, and all of those things go in our favour in Queensland. Climate change and COVID, I would say that COVID is very much a sort of a man-made phenomenon, if you like. But I don't think it's climate change. I think it's how we interact with our zoonotic friends to do with you know, wet markets and encroaching on natural habitat and eating of, you know, live animal trade and all of those factors, which are getting more and more concerning. And I think we have seen a whole bunch of almost pandemics come through. I mean, we saw the original SARS, we've seen MERS, we've got, you know, Zika and a whole bunch of others. I think it's almost inevitable that there will be another pandemic, and it will be sooner rather than later. We're not going to be waiting another 100 years for the next one unless we change the way we interact with our environment.
Thanks, Emma. There are a couple of questions about the vaccines themselves. So one, I think you pretty much addressed in your speech, which was really around, did the slow rollout of vaccination impact on the evolution of COVID-19? But there are also a couple of other questions around, you know, how do we understand the impact of a mix of vaccines providing greater protection? Is that right, rather than just going with a single vaccine? And then there are questions further down around children, and there's questions around how do you try and encourage people who are hesitant to get the vaccine, I suppose, but really about is this a good idea for very small children? Can you see that day coming?
Okay, all right, lots to get through there. All right. Slow rollout was incredibly frustrating, and one of the biggest, I guess, mistakes of Australia's response to COVID. But I don't think it led to an evolution of COVID. Well, certainly the fact that we've had so much transmission has helped with the evolution of COVID, because the more times that the virus replicates, the more opportunity it has to evolve. But it hasn't evolved very much against vaccines, but we may see that next. I mean, my biggest concern is that we have a Delta style variant that is also a vaccine escape variant that might be on the horizons. Second question, mixing of vaccines, is it better than staying with one? Well, the evidence is all that's available at the moment is mostly about having 3 Pfizers, and 3 Pfizers is a lot better than 2 Pfizers. So that's where the evidence is. So we need to have a third vaccine for some people or a booster. At the moment, the evidence is all with Pfizer, but I certainly wouldn't. But what's also been shown is that an AstraZeneca followed by a Pfizer is very good protection too. So if you've been vaccinated with either AstraZeneca or with Pfizer, your next vaccine, should you wish to accept it, should be a Pfizer. I personally would like to see Moderna also used for this, because I do think that there's some value in mixing. All right. Now about children and hesitancy. And so, of course, as we go down the age groups, the severity of COVID is less and less and less. So do we get to a point where it's just not worth vaccinating people as they're younger? I don't think so. I think it's going to be worth vaccinating everyone as the evidence comes in that it's safe and effective to do so. And up until today, that evidence is in for 5-year-olds and plus. So I would definitely recommend that they get vaccinated. And I think one day it will be a routine vaccine in infants as well. And partly they're doing, if we do recommend that, it'll be for this notion of herd protection, not necessarily direct protection for the person getting the vaccine, although we do vaccinate children for things like meningococcus, which is incredibly rare. So death from COVID in children will be incredibly rare, but around the same or even slightly more than what we're doing for meningococcus. So I don't see a problem with vaccinating children for their own benefit and also for herd protection as well.
So we might make this the last one then. There's a question about what proportion of people are likely to end up with long COVID that we've heard about, and why are some susceptible to this?
Okay, another slide I had to cull from my pack. The people who are susceptible for long COVID are similar to the people who are susceptible to COVID. Older people, people with cardiovascular disease and obesity, and where is my long COVID slide? And there we go. And people with hypertension and so on. All right. So they're the people who are likely to get long COVID. So it's going to be rare in children, but not zero. And in fact, that is another reason for vaccinating children, because it's sort of, in the few percent of children will get long COVID. And that's a pretty nasty thing to have to deal with. And long COVID does lead to a bunch of things that you really don't want, like cognitive changes, depression potentially, shortness of breath that can go on for many, many weeks and beyond, aches and pains and so on. So yeah, so long COVID is another whole total topic, and certainly while it's children are relatively protected, it does happen in several percent of children as well.
Well, thank you, Emma. I think maybe what we'll do is leave it there for today. There were other questions too about the experience of other countries and, what have we learnt from them. There were questions about JCU's own policy settings going forward, so we'll have to have a good think about some of that. But if I can, on behalf of all of those, and we've had quite a few hundred people listening in, Emma, thank you so very much for being JCU's 2021 Last Lecturer for this year. I think it's been a tour de force. I just think you're absolutely stunningly marvellous. Thank you so much for all of your work on this over the last couple of years, and indeed providing the leadership you are right now. We're very, very lucky to have you. So I know that out there in cyberspace, all of my colleagues and people in the broader community are paying tribute to you and thanking you very much today, Emma, for all your efforts. Thank you so much indeed.
All right. Well, thank you very much for having me. It's been an absolute pleasure. And thanks for the excellent questions. Questions that I've had through the last 18 months have always been exceptionally insightful and made me think. So thanks again.
Good on you.
Listening. Cheers.
And the webinar has ended. Thank you very much, everybody. Bye for now.